Welcome to this Step 3 review on multiple choice question strategy, brought to you by Roadmap to Residency. Step 3 rewards the doctor who thinks about what to do next in the real world, especially in the outpatient clinic, and who chooses care that is appropriate and cost-effective. Our goal today is not to reteach medicine, but to show you how question stems are built and how to attack them. Keep working through your question bank alongside this video. Let's get started. Here is what we will cover. First, how to read the clinical vignette the way a working physician does, asking what the next best step actually is. Second, the themes Step 3 loves: outpatient management, ordering only appropriate tests, and cost-effective care. Third, a time management plan for both halves of the exam, the multiple choice blocks, and the case simulation. Along the way, we will work through several practice questions together. This video assumes baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is to read every vignette like a physician deciding what to do next. Start with the last line of the question. That tells you what is actually being asked, whether it is the next best step, the most appropriate test, or the best treatment. Then read the stem with that goal in mind, and you will stop drowning in detail. Next, anchor on the setting. A stable patient in your clinic pushes you toward outpatient workup, while the same complaint in the emergency department can change the right answer entirely. Where the patient is being seen is a clue, not background noise. Strategy 2 is the outpatient management mindset, the biggest shift that trips people up. First, default to the clinic. When the patient has normal vitals, no red flags, and reliable follow-up, the test usually rewards managing them as an outpatient rather than admitting or ordering an aggressive workup. Be suspicious of any answer that admits a stable patient or orders expensive testing without a clear reason. Second, manage the whole patient. Watch for answers about counseling, lifestyle change, vaccination, screening that is due, and follow-up. When two answers are both reasonable, the stronger one often also handles prevention and continuity of care. Strategy 3 is cost-effectiveness and appropriateness. First, start with the cheapest useful test. When choices range from a focused history to a basic test to advanced imaging, the next best step is usually the simplest test that actually changes what you would do. Save the expensive scan for after the cheaper step is done, or clearly not enough. Second, match the test to the pre-test probability. A low-risk patient does not need an aggressive workup, and a high-risk patient should not be sent home. Third, beware the tempting overkill answer. The writers love to plant an impressive-sounding option that does far more than this patient needs. On this exam, doing too much is wrong just as often as doing too little. Let's work through our first practice question, built to test the outpatient mindset. A 55-year-old man comes to your clinic with chest tightness that comes on with brisk walking and resolves after a few minutes of rest. He has high blood pressure and high cholesterol. His vitals are normal, he is comfortable, his office electrocardiogram is normal, and he can walk on a treadmill. The question asks for the most appropriate next step. Notice the setting and the stability of the patient, read the options and pick your answer, then we will reason through it together. Let's break this down. Step 1, spot the pattern. We have stable, predictable chest pain with effort that resolves with rest in a patient with cardiac risk factors who is comfortable with normal vitals and a normal tracing. That is stable angina, not an emergency. Step 2, apply the rule. For a stable patient who can exercise and has a normal baseline tracing, the appropriate next step is an exercise treadmill stress test, keeping the workup outpatient. Step 3, eliminate the rest. Admitting for urgent angiography is overkill. Coronary CT angiography is not the standard first step here. Reassurance alone dismisses a real concern. The correct answer is the exercise treadmill stress test. Here is our second question, all about cost-effectiveness and appropriate testing. A 40-year-old woman comes in with low back pain for 2 weeks after moving furniture. The pain is worse with bending and better with rest. Crucially, she has no fever, no weight loss, no leg weakness, no numbness, and no loss of bladder or bowel control, and her neurologic exam is normal. The question asks for the most appropriate next step. Scan the stem for red flags, find none, and choose care proportionate to a simple problem. Pick your answer, and we will reason through it next. Let's work through this. First, scan for red flags. The stem walks through them and tells you they are all absent. No fever, no weight loss, no weakness, no numbness, no bladder or bowel changes, and a normal exam. With a clear mechanical cause and a clean exam, this is uncomplicated low back pain, and imaging is not indicated in the first several weeks. So conservative care wins. Reassurance, staying active as tolerated, and simple pain control is both appropriate and cost-effective. MRI and plain films are wrong with no red flags, and that scan is the classic overkill trap. Referral to a spine surgeon is far too aggressive. The correct answer is reassurance, activity as tolerated, and analgesia. Let's talk time management, because this is a 2-day marathon and pacing is where strong test takers lose points. There are 480 questions total across 2 days, broken into timed blocks, giving you a little over 1 minute per question on average. First, know the clock and practice at that speed in your question bank so the rhythm feels automatic. Second, learn to flag, move on, and bank time. If a question has stalled you for more than about 90 seconds, lock in your best guess, flag it, and move forward, because letting one long vignette swallow the time of 3 others is how blocks go unfinished. Use your break time wisely so you arrive at day 2 rested. Here is our third question, which rewards the whole patient-outpatient mindset. A 60-year-old woman with type 2 diabetes comes in for routine follow-up. She feels well, her blood sugar is at goal on metformin, her vitals are normal, and her exam is unremarkable. The one detail that should jump out is that she has not had her eyes checked in 2 years. The question asks for the most appropriate next step. Think about what preventive care is actually due, and don't get pulled toward an answer that does too much. Choose your answer, and we will reason through it next. Let's break this down. First, spot the screening gap. This is a stable diabetic patient at goal on metformin who has not had her eyes checked in 2 years. A yearly dilated eye exam is part of routine diabetes care, so referring her for the dilated retinal exam is the preventive care that is due, reflecting the whole patient mindset. Now, the wrong choice is coronary CT angiography is the overkill trap in a patient with no cardiac symptoms. Admitting a well patient at goal for inpatient glucose monitoring is inappropriate and expensive. Stopping metformin for insulin makes no sense when her control is at goal. The correct answer is to refer her for the dilated retinal eye examination. Here is a critical exam day pearl that ties the pacing advice together. The 2-pass strategy for each block. On your first pass, answer every straightforward question and commit without lingering. For any question that makes you hesitate, pick your best option, flag it, and keep moving, so you reach the end of the block with everything answered and your pace intact. On your second pass, go back to only the flagged questions. Resist the urge to second-guess answers you felt confident about, because a first instinct grounded in a clear rule is usually correct. Only change an answer when you find concrete evidence you misread the stem. This protects your time and your score. Now, the second half of the exam, the computer-based case simulation. This is the interactive portion where you manage a patient over simulated time, ordering tests and treatments and advancing the clock. Cases come in 2 lengths, and the software tells you the real-time limit. A short case gives about 10 minutes and is usually a focused problem, so get in, stabilize, order what matters, and get out. A longer case gives about 20 minutes and is broader, often with more than one issue to manage. Second, prioritize the sickest actions first. Your opening moves should address anything that threatens the patient now, before routine or confirmatory tests. Place the patient in the right location, start urgent treatment and supportive care, and only then order the workup. Let's talk about the clock inside a case, because the simulation is a time management test in disguise. First, do the safe orders before you advance the clock, so treatment begins as early as possible in the patient timeline. Ordering the right thing late can still cost you credit. Second, move the clock in reasonable steps and reassess. Advance the simulated time to when a result would return or treatment would take effect, then respond to how the patient changed. Do not jump hours ahead in one leap and miss a chance to react. Third, know when to end the case. When the patient is stable, the main problem is being treated, and follow-up is arranged. It is time to stop, even if the real time is not fully used. Adding one more test rarely helps and can work against you. Finally, let's build a practice schedule so all of this becomes second nature. First, separate your practice the way the exam is separated. Spend most of your daily practice on timed multiple-choice blocks to build pacing and pattern recognition, and set aside dedicated sessions for the case simulation software so the interface never surprises you. Fumbling with how to place an order wastes time you don't have. Second, rehearse full cases under realistic timing using the official practice software so ordering, advancing the clock, and closing feel automatic. Complete several cases per session and review each one to see what you missed or ordered too late. Build this into a steady weekly rhythm rather than cramming at the end. That wraps up our Step 3 review. Read every vignette like a physician deciding what to do next, and start with the last line. Lean into outpatient management, appropriate testing, and cost-effective care, and stay alert for the overkill answer. Protect your time with the 2-pass strategy, and in the case simulation, order urgent actions early, advance the clock in steps, and close once the patient is stable. Lock it in by drilling timed questions and rehearsing full practice cases, and read every explanation. Visit roadmaptoresidency.com for expert tutors and advisors. If this video helped, please like and subscribe. Good luck on your exam, and we will see you next time.